So I first met Dr. Weltz because she put in my chemo port, which helps them give me the chemo in one location subcutaneously. And she said, "I'm fascinated by your case. Did you know I'm studying this?" I said, "No." So suddenly I had this wealth of information.
The work that I'm doing relates to women who have had a mastectomy, whether it's for cancer, whether it's preventatively, as was your situation, or whether it's for an early form of cancer, namely ductal carcinoma in situ. And what I'm specifically looking at is when a new breast cancer arises after the mastectomy. I'm looking at new breast cancers that develop after a mastectomy that are arising in what we call retained breast tissue. And what I mean by that is that the mastectomy did not remove all of the breast tissue.
How common is a mastectomy in which a large amount of breast tissue is left behind?
Fortunately, it's not common. Fortunately, most mastectomies do adequately remove breast tissue. So the phenomenon that happened to you and the phenomenon that happened to the multiple patients that I'm studying is relatively uncommon, which is fortunate. There are various reasons, I believe, why it is happening. It's frustrating that I predict we're going to see more of this in years to come. I think we're pushing the boundaries with regard to how we are doing mastectomy. We're pushing the boundaries cosmetically. The things that have evolved in the last decade or so are not bad things if they can be done properly. From a cosmetic point of view, they're very, very good things. These include what we call skin-sparing mastectomies, where we save all of the skin except for the nipple, and that enables a much more natural-looking reconstruction. We're doing nipple-sparing mastectomies, where we save all of the skin, including the nipple. Needless to say, that has a very, very good cosmetic outcome. We're doing mastectomies through smaller and smaller incisions, and we're doing mastectomies through what's called the inframammary fold, which is the tissue, excuse me, which is the, we're doing mastectomies through the inframammary fold, which is a beautiful place to make an incision, but as you get from underneath the breast, but as you're getting to the top of the breast, your visualization is limited, your exposure is limited.
So you might miss tissue.
You might miss tissue on the very top of the breast or the very upper lateral part of the breast near the axilla.
Dr. Weltz really cares about women going through this procedure and the choices they're making.
I think the lesson is A, to be aware of this phenomenon. Not only such that we can prevent it, but that we can do a better job in following people over the long term. In the research that I'm doing, the vast majority of patients find this new breast cancer on their own. Even when they find something that's subtle, perhaps in the skin, they don't necessarily realize what's going on. Some of these women actually go from doctor to doctor, internist, dermatologist, back to their original breast surgeon or another surgeon if their original breast surgeon is not practicing. And this can even in and of itself lead to a delay in the diagnosis.
It can cost a woman her life.
And it can cost a woman her life. We have to do better at screening these women over the longer term, and nobody's keeping an eye on them until they find something.
No one was following me.
That is typical. The other message that I think needs to get out there is that even though this is a rare phenomenon, one can't write it off to, oh, this happens, but uncommonly, what's the big deal? This is a devastating thing for the individual who is affected. And no such thing should ever be looked at numerically or statistically. It's something that simply should not happen.
There are so many young women going in now who maybe BRCA, maybe they have a variant, maybe they have a strong family history. They're going in and they're making these really difficult choices, and they're looking for surgeons, and they are looking for procedures, and they want a cosmetic result, or maybe they don't, and there's so many things to consider. But I am telling them, and I am pleading with them, to have the conversation about getting it all out.
A very honest conversation take place before the surgery is done between the patient, the breast surgeon, and the reconstructive surgeon. And part of that conversation needs to include, is our number one goal here to get all of the breast tissue out? Is there any reason the patient, would need to be concerned that that could in any way be compromised? And I think that will be a very, very meaningful conversation. The reality is that a very good breast surgeon working with a very good reconstructive surgeon can accomplish both things.
So if you're a 20 or 30-year-old walking in to interview a surgeon, to meet with a surgeon, it seems redundant, or it seems weird that you would have to say, are you going to get it all out? But you're saying that's a really important question.
You're absolutely right.
Get it all out of me.
It is a really important question. Surgeons will say, we never get 100% of the breast tissue out. That's fine, but what we're talking about as it relates to what happened to you is a very different thing. Every mastectomy that's done has to be done with the number one goal of removing all of the breast tissue. That's ultimately where we need to be.
I thought that's what I had.
I know. And that's what's so upsetting about this, because you, as with so many patients in my study, had no idea whatsoever that this could happen. And that leaves you sort of a victim. And that compounded by the fact that decades will often go by. It's very different from your typical surgical complication. Breast cancer developing in residual breast tissue 20 years after the mastectomy is the type of complication that may never even get recognized as a complication.
And compounded with lifetime risk.
Breast tissue that's left behind in a woman who carries a genetic mutation, such as a BRCA1 mutation, is definitely higher risk breast tissue. We don't know if a little bit here and a little bit there makes a difference. We don't know if there's a critical mass of tissue and how it receives blood flow makes a difference. These are things that we don't know and would be interesting to know.
So your reaction to my case is it never should have happened.
It never should have happened, but I know you're going to be fine. And that's ultimately what matters.